Hi everyone, this is Jake Russell. I'm going to be presenting my complex case scenario presentation for the Capstone Unit XNH480 on my client named Mr. PC. Getting into the patient summary, Mr. PC first presented to the Sporting Wheelies and Disabled Association, which is where I had my practicum in 2013 after having suffered a TBI 5 years prior to presentation, so in 2008, which is 9 years ago now, he suffered the TBI. At the time, the TBI was caused by a blunt trauma in a car accident, and the reason he actually got into that car accident was because he had a stroke while driving. So, stroke along with TBI is the principal diagnosis for this patient. And the client had performed little to no rehabilitation prior to coming into the clinic, so he was quite deconditioned at the time. Getting into some of the patient's details, his height upon presentation was 195 centimeters, his weight was 190 kilograms, and he is currently age 36. He initially presented in an automatic chair, but has since moved to using a manual chair in the gym. And when he's coming to the gym, I believe he still uses an automatic chair at home because he can't do a whole lot in the manual chair in terms of function and independence. But we did promote the use of the manual chair just for them to get a feeling of what it's like to move toward being a bit more independent, I suppose. As I said previously, Mr. PC presented as one of the most deconditioned TBI clients I'd seen in terms of function and in terms of independence as well, upon just eyeballing it initially when he came in. But despite this, probably the best thing about working with Mr. PC was he was always cheerful, and when asked how he was doing, he'd always respond with superb or excellent or something like that. So that was always really good to see. Going into the medical history and complications for Mr. PC, the principal diagnosis I also mentioned earlier was a traumatic brain injury and a stroke, which he suffered simultaneously. Complications since then have pretty much presented immediately after and as a result of the traumatic brain injury and stroke. Hypertonia in the form of spasticity, which I'll talk a bit more about later on. Chronic venous insufficiency, primarily in the lower extremity. Mild dysphagia and cognitive impairment. Keyhole brain surgery, which happened in the few days immediately after his accident, which he had his TBI in. He's also currently wheelchair bound and disabled. And the medications Mr. PC is on is clothalidone, which is a diuretic, warfarin, and baclofen. We've performed 4 pieces of assessment throughout this client's regular assessment. The first being BMI. You can see he had a 3% improvement, but he's still in that overweight category. The second being a 6-minute wheelchair push test, which is essentially like a 6-minute walk test, but instead of walking, he's obviously pushing a wheelchair. I was a bit surprised by how little the client was able to actually perform in this, but due to his hypertonia and his spasticity, he really struggled with actually pushing the chair, but alas, he still had a 50% improvement, which was good to see. Modified functional reach test. You can sort of see here what I was talking about earlier with his left side being a bit more affected with his right. The score for both the forward and lateral reach are lower in his left side than his right side, and it was good to see he had an improvement in this recent assessment, the forward lateral reach and on left right, so everything assessed in that test was improved. The last piece of assessment we performed was a functional independence measure, where it's essentially a survey of the amount of independence that he has and the amount of assistance he requires when performing ADLs. It consists of a motor score and a cognitive score. His cognitive score did not improve, but his motor score went up by 2 points, which was good to see. The assessments that we performed are all backed up by literature. I'll let you look at the Word document if you're a bit more interested in this. For time constraints, I'm just going to sort of gloss over this, but essentially everything is supported by literature that we have performed. The exercises that we have actually performed are as follows. First of all, a recumbent bike with a passive upper limb stretch, and a trainer had to assist the movement of the right leg and ensuring it was abducted throughout that exercise. Secondly, a seated cross trainer with intervals with the hands on the handles and a trainer again assisting that leg movement. The intervals with the hands on the handles were essentially because the client wasn't able to hold those handles for the entire duration, and what holding those handles actually provided for him was a form of passive stretch. So it included passive stretching in the recumbent bike and in the seated cross trainer. And which leads me into the next exercise, just purely passive stretching with also applying deep muscle stimulation, which is DMS. We passively stretch out and applied DMS to the client's quads, hip flexors, hamstrings, biceps, and pec major, which were some of the tighter muscle groups that we were able to eyeball and that we were able to identify and that the patient identified himself. The final exercise we performed is a weight-assisted glute bridge to failure, and it was performed to failure essentially so we could get as many reps out as possible. I'll justify that in the research a bit more later on. This is performed supine on a plinth with knees flexed at 90 degrees and a gait belt position underneath the client's hips, which is attached to weighted cables on either side. And we had 50 kilograms of weight on each side, so 100 kilograms total, assisting him with that hip extension. And the reason we had this much weight was because we needed him to get through that entire range of motion, and we wanted him to perform a lot of reps as well. So it was essentially sort of lightweight, high repetition resistance training, which is why we had to have so much, because he could barely perform the range of motion without at least that much weight. The reasons why we chose to perform a recumbent bike and a seated cross trainer was because we were able to provide a passive stretch in both exercises while still providing an excellent form of cardiovascular exercise. Some other benefits that are supported by the literature for these exercises include skeletal muscle pump activation, which will help with his chronic venous insufficiency and venous return. Rhythmic exercise for motor pattern learning. So essentially, relearning motor patterns is important for relearning gait and also performing various other functional tasks. And this sort of rhythmic exercise, such as cycling, can assist with that. The fact that it can be performed in a chair was another huge one. Bone loading is something that you might not think of recumbent bike or seated cross trainer as great forms of bone loading for other populations, but for a population such as Mr. PC who can't actually get out of the chair and get into some more impact loading exercises, this is actually a pretty good form of bone loading, and one of the better ways that we were able to incorporate something that we wanted to do as clinicians into having an exercise that also incorporates his goals and that he wants to do. Also, weight loss and regular cardiovascular exercise benefits are also shown here, and we're also getting activation of central pattern generators for lower limb movement, which could eventually help with gait and standing and for those extension responses further down the line. Another reason we chose these exercises specifically was because other seated exercises, such as an arm ergometer, were impossible due to the amount of spasticity and hypertonia in the client's fingers. The reason that we decided to prescribe passive stretching for Mr. PC was it has been shown to reduce spasticity according to a study by Evans SH, but in order to reduce the spasticity and hypertonia in general, the passive stretching must be performed frequently and for a prolonged period of time is what this study found, which is why we decided to perform passive stretching throughout the previous two exercises and have exercise devoted to purely passive stretching of multiple muscle groups at the same time. We focused the passive stretching on the muscle groups that appeared to be most affected by the hypertonia and spasticity that I mentioned before, the hip flexors, the internal rotators, and biceps particularly. And we used DMS, or deep muscle stimulation, because it has been anecdotally reported amongst clients to temporarily loosen and relax muscles. And this client also reported that it did that for him and it helped him in that way. And it also, doing this passive stretching was important to increase the range of motion temporarily for exercises that we performed after that, but particularly performing the next exercise, the weight assisted glute bridge, really loosening up those hip flexors so that he could go through that full range of hip extension was very important for us. Reasons that we decided to form the glute bridge, the weight assisted glute bridge, were to target the hip extensors to combat one of the major areas of spasticity in the hip flexors, and to achieve his eventual goal of standing and walking with a walking aid. We used 100 kilograms, as I said, combined, 50 on each side, which was what was required for the patient to actually go through the entire range of motion. So we had to prescribe something like that. And the reason we performed such lightweight resistance training for many reps is that it has actually been shown to be ideal for traumatic brain injury clients for increasing neural activation of the muscle groups that are being targeted. Upon reflection, some of the things that probably influenced me to prescribe the exercises that I did for this client was having performed similar exercises with SCI clients in particular that had similar levels of innovation in the past. Also, a barrier that we overcame was choosing exercises that accomplish the client's goals while still fitting in what we as clinicians deem necessary and appropriate to have in exercise. We did this by doing cardiovascular exercises, which was something that was appropriate for the client's goals, while still adding in passive stretch at the same time, sort of killing two birds with one stone, so to speak. In the future, if I were to work with a similar client to Mr. PC, I would make sure to pay extra attention to the amount of pain tolerance and how they tolerate passive stretching, because it can be quite painful. Thank you for listening. That concludes my presentation.